Welcome back to another explainer. Today we're diving deep into the Bradyarrhythmias, specifically focusing on a really fascinating and critical piece of your heart's electrical system, the atrioventricular, or AV, node. Think of the AV node as your heart's essential electrical gatekeeper. It has this incredibly vital job of managing every single electrical signal traveling from the upper chambers, the atria, down to the lower pumping chambers, the ventricles. When this gatekeeper is doing its job perfectly, your heart beats in a smooth, synchronized, efficient rhythm. But when it starts to falter, well, that's when we see rhythm disorders and we get into the bradyarrhythmias we're exploring today.
All right, let's dive right in. Here's our roadmap for today. We'll start with the electrical gatekeeper, move on to decoding the ECG blocks, then look at why blocks happen, map out the diagnostic pathway, and finally wrap up with when to pace.
Section 1. The electrical gatekeeper.
So, let's start with the anatomy and baseline function of this really remarkable little structure. And I do mean little. The compact AV node is tiny. It's roughly 1 by 3 by 5 millimeters, sitting strategically right beneath the right atrial endocardium at the apex of a region we call the triangle of Koch. Its absolute main role is protective. It stands right between the rapidly firing atria and your vulnerable ventricles. To do this, the AV node uses this incredibly unique physiological trick known as decremental conduction. Basically, what this means is that as the rate of electrical stimulation from the atria speeds up, the AV node actually hits the brakes. It slows down the conduction of that signal. This built-in delay is absolutely crucial. It gives the atria the split second they need to fully contract and push blood into the ventricles before the ventricles themselves are told to fire. Plus, if the atria suddenly go haywire and start firing at dangerously high rates, like you'd see in atrial fibrillation, this decremental property protects the ventricles from getting totally overwhelmed. It's an anatomical bottleneck, and it's there for your protection.
Now, what's really cool is how this delay happens at the cellular level. Unlike your standard atrial or ventricular muscle cells, the myocytes right inside the compact AV node are actually missing something. They lack a robust presence of fast sodium channels. Because they don't have that rapid inward sodium current, the initial upstroke of their action potential, which we call phase 0, is driven instead by much slower calcium currents. This physical limitation right at the cell membrane, combined with a pretty sparse expression of gap junctions connecting these cells, is exactly what slows down the electrical signal as it travels through the node. It's just brilliant biological engineering.
But the AV node isn't just a fancy resistor. It's also a vital backup generator for the whole system. If your heart's primary pacemaker, the sinoatrial node, fails to fire, the AV node has its own intrinsic automaticity. It will just spontaneously generate a rhythm of 20 to 60 beats per minute. Now, under normal circumstances, the faster sinus node overrides this completely. But if things go dark upstream, this built-in 20 to 60 beat per minute backup rate can literally be a lifesaver, keeping your ventricles pumping and keeping you alive.
Moving on to Section 2, decoding the ECG blocks.
So what exactly happens when this gatekeeper gets diseased or damaged? This is where we cross over from normal physiology into pathophysiology. Clinically, we figure this out using an ECG, grouping these malfunctions into different degrees of AV conduction block. Let's look at the two extremes first, first degree and third degree block. First degree block is honestly pretty mild. Every single impulse from the atria is still making it to the ventricles, but the delay through the node is abnormally long. We see this as a fixed PR interval of more than 200 milliseconds. Actually, scratch the word block for a second. It's more of a prolonged delay than a true block. On the absolute other extreme, you have third degree or a complete heart block. This means there's a total electrical interruption. The atria and ventricles become completely dissociated. They're just beating independently of one another, with the ventricles relying on a much slower, precarious escape rhythm.
Now, what's really interesting here is the gray area in the middle, second-degree block, where conduction fails intermittently. We split this into two types, and knowing the difference is crucial. Mobitz type I, also called Wenckebach, shows this progressive lengthening of the PR interval beat after beat until finally a beat is dropped. This usually happens right within the AV node itself, and honestly, it's generally pretty stable. Mobitz type 2, on the other hand, that is a massive red flag. Here, the PR interval remains totally fixed, completely normal, right up until a sudden, unpredictable dropped beat. This tells us the block isn't in the AV node itself, but lower down in the His-Purkinje system. It's highly unstable, and it carries a severe risk of just suddenly dropping into complete heart block without any warning.
Section 3. Why do blocks happen?
Okay, so understanding the ECG is a great first step. But to truly grasp these bradyarrhythmias, we need to ask, what is actually physically breaking down the heart's gatekeeper? We can basically group the main structural threats into 3 buckets. First, idiopathic progressive fibrosis. This accounts for roughly 50% of acquired blocks. We're talking about senile degeneration like Lev's disease or Lenegre's disease, which hits the distal bundles in younger patients. Then we have ischemic causes. An inferior myocardial infarction often causes a transient reversible block right at the AV node. An anterior MI, though, far more dangerous. It tends to wipe out the distal conduction system below the node, and that carries a much higher mortality risk. Finally, we have infiltrative diseases, things like sarcoidosis or amyloidosis. These physically deposit abnormal proteins or cells into the nodal tissue, literally destroying its ability to conduct electricity.
Section 4. The diagnostic pathway. With so many potential underlying culprits, how do we practically approach a patient who shows up with an AV block? Well, we don't guess. We follow a very specific clinical algorithm. And the central question driving this whole diagnostic pathway is this: how do we pinpoint the exact anatomical level of the block? Is the delay happening inside the AV node itself, or is it happening lower down, infranodally, in the Hesper-Kenji system? Nailing this down completely changes the patient's prognosis. Nodal blocks usually have reliable, narrow complex escape rhythms, but infranodal blocks, they rely on wide, slow, highly unreliable ventricular escape rhythms that can very easily degrade into sudden cardiac death. So knowing the level is absolutely everything.
And this leads us perfectly into an if-then diagnostic pathway. Step 1 is almost always an echocardiogram. We need to evaluate the heart for any underlying structural or valvular disease. Step 2, especially if the patient is having symptoms, involves exercise testing or ambulatory ECG monitoring. We want to catch the rhythm in action and see exactly how the block responds when the heart is stressed. And finally, step 3 is crucial. If a patient presents with an unexplained AV block and they are 60 years old or younger, that is a huge signal. It warrants a deep dive with advanced imaging like a cardiac MRI or a PET scan, specifically to hunt for those sneaky infiltrative diseases like the sarcoidosis we just talked about.
Section 5. When to pace.
Once we've identified the block and its level, we hit the final clinical hurdle, management. Because we're dealing with a broken electrical gatekeeper, medications are rarely a permanent fix here. We have to decide when installing a mechanical backup system, a pacemaker, is absolutely necessary. Now, the foundational rule of management here is pretty clear. Yes, some blocks are transient, like the ones caused by a reversible inferior MI, or maybe high vagal tone in young athletes, but acquired and persistently symptomatic blocks require intervention. If the fibrosis or the cellular damage is permanent, then permanent pacing is literally the only reliable therapy we have to restore normal heart rate and get rid of the patient's fatigue or fainting spells.
So, the most crucial thing to take away from this is knowing exactly which blocks cross the threshold for intervention. Class 1 indications, which means a pacemaker is definitively required, include any form of complete heart block and any advanced AV block. But check this out. Second-degree Mobitz type 2 is on this list regardless of whether the patient has symptoms or not. Remember how we said it's an infranodal block with a huge risk of progressing to sudden asystole? Because of that ticking time bomb, we pace these patients even if they tell us they feel perfectly fine. On the flip side, Mobitz type 1 and first-degree blocks generally only earn a pacemaker if they're actively causing major symptoms or if the patient also has certain high-risk neuromuscular diseases.
Okay, we've covered the physiology, the ECG readouts, the underlying causes, and the interventions. But I want to leave you with one final, slightly provocative thought to chew on. If the AV node evolved specifically to delay conduction and ensure this perfectly synchronized sequential contraction of the heart, what happens over the span of years or even decades when we permanently bypass that intricate native system with a traditional pacemaker wire just sitting in the right ventricle? Traditional pacing saves lives, absolutely, no question, but it fundamentally alters the heart's natural mechanical sequence. It's a huge question that really highlights the long-term stakes of this intervention, and it's exactly what's driving the fascinating, emerging field of left bundle branch area pacing. But hey, that's a whole other topic for a future explainer. Thanks for exploring the AV node with me today. Stay curious and keep learning.